Welcome back to the deep dive. Our mission, as always, is to take these dense, incredibly detailed sources. Today, it's foundational texts in pathology and just give you the ultimate shortcut to really getting it.
And today's topic, neoplasia, or new growth, is one that I think is widely misunderstood.
It really is. You hear the word cancer and you think it's this one single enemy. But what our sources make so clear is that it's not one disease at all. It's a huge spectrum.
It absolutely is. I mean, think about the contrast. On one side, you have something like a localized lymphoma, which can be very manageable, even curable.
Right.
And on the other, you have something like pancreatic adenocarcinoma, which is often devastatingly fast. The difference in the outcome, the whole emotional journey, it's just night and day.
So for a pathologist staring down a microscope at a biopsy, what's the single most important call they have to make?
It's this. Is this new growth benign, meaning it's going to stay put and probably not cause serious harm? Or is it malignant? Is it destructive, invasive, and capable of spreading?
Exactly. So what we're going to do is unpack this. Our sources lay out these four critical characteristics, almost like four pillars of evidence that pathologists use to draw that line.
We're going to walk you through that whole investigation. From the tiniest details inside a single cell, all the way up to how a mass behaves in the body.
You really need to understand these four things to grasp the difference between, a minor issue and a life-changing diagnosis.
It's the classification system. We're looking at what the cells look like, how they're organized, how they behave mechanically, and finally, their ability to travel.
Okay, so let's start with pillar number one, the most microscopic piece of evidence, the cell itself. We start with this concept called differentiation.
Right. And differentiation, put simply, is just how much the tumor cell still looks and acts like the normal, healthy cell it came from.
And for benign tumors, the news here is generally pretty good, isn't it?
It is. The vast majority are what we call well-differentiated. The tumor cells look a lot like their normal counterparts. Their structure, their shape, it's all very similar.
You gave the example of a lipoma, a benign fat tumor. Under the microscope, it looks so much like normal fat tissue that
if it weren't growing as this distinct lump, you might just miss it. It's a really good example. And they can even retain their function.
Oh, right, like an endocrine tumor still pumping out hormones.
Exactly, still making hormones, just maybe not when it's supposed to. But when you get to malignant tumors, you often see the complete opposite, a state we call anaplasia.
Which literally means to form backward. So this is cellular chaos.
It's total cellular chaos. And anaplasia is really the hallmark of malignancy. It's the microscopic picture that screams danger.
So what are the specific red flags? When you look down that microscope, what are the telltale signs you're looking for?
Well, there are a few key features. The first is pleomorphism.
Okay, what's that?
It's just a huge variation in the size and shape of the cells within the same tumor. You'll see these tiny little primitive-looking cells right next to these enormous, bizarre cells we call tumor giant cells.
So there's no uniformity at all?
None. It's that anarchy that tells you something is deeply wrong with the genetic machinery.
And that broken machinery, it shows up in the cell's control room, the nucleus, right?
It absolutely does. That's the second sign. Abnormal nuclear morphology. In a normal cell, the nucleus is, maybe a quarter or a sixth of the cell's volume.
Pretty small.
Right. In anaplastic cells, that nucleus just takes over. It becomes huge, sometimes almost as big as the rest of the cell, a 1-to-1 ratio.
And it's not just big, it looks wrong.
It looks very wrong. It's irregular in shape, and the chromatin, the DNA inside, is all clumped up and coarse. It stains really dark, which we call hyperchromatic. It's just a visual signal of complete DNA disarray.
Okay, so that's two. What's the third sign?
It's about cell division,
Yeah.
right? Because lots of tissues divide quickly normally.
That is a critical point. Your gut lining, your bone marrow, they have a lot of cells dividing, a lot of mitosis. So just seeing cell division isn't enough.
So what's the difference? It's the quality of the division. In cancer, we see atypical, bizarre mitotic figures. Instead of a clean split into two new cells, you see these monstrosities. Tripolar spindles, where a cell tries to divide into 3 or 4.
Wow.
These are a dead giveaway for malignancy.
And the last sign is that the cells just lose their sense of direction?
Yes, loss of polarity. Think of normal tissue as a perfectly built brick wall. Every brick, every cell has its place. Anaplastic cells, they've lost the blueprint. They just pile up in disorganized heaps.
That whole picture, the pleomorphism, the messed up nuclei, the weird mitosis, and the loss of order. That's anaplasia.
That's anaplasia.
What I find so interesting is what this does to the cell's function. Our sources say they usually lose their specialized jobs, but sometimes they learn new, unexpected tricks.
This is one of the most fascinating and dangerous parts of cancer. We call them paraneoplastic syndromes. You might have a patient with Cushing syndrome, which is caused by too much cortisol.
So you look at the adrenal gland.
You would, but in this case, the source isn't the adrenal gland at all. It's a small cancer in the lung, a bronchogenic carcinoma, that has somehow taught itself to make a hormone that stimulates the adrenals. It's a stunning biological twist.
Okay, so we've nailed down the microscopic view. Let's pull the lens back now and look at behavior. Pillar 2. How the mass acts in the body. Is it a good neighbor or a destructive one?
This is where that ancient name for the disease, carcinos or crab, really comes from. It's all about how it grows.
Let's start with the benign tumor. How does it behave?
A benign tumor is typically a cohesive, expanding mass. It grows, but it grows by pushing. It pushes the normal tissue around it aside.
And that pushing creates something really important, doesn't it?
It does. It creates a capsule. It's a rim of compressed fibrous tissue that forms around the tumor.
And that capsule is a surgeon's best friend.
Absolutely, because it creates this clean plane, this boundary. It makes the tumor a discrete, movable lump that can often be, just popped out. We call it surgical enucleation.
Like a fibroadenoma in the breast. It's usually a clean removal.
A perfect example. But malignant tumors, they don't play by those rules.
They don't respect boundaries.
No, they are poorly demarcated. They don't have that nice, clean edge. Instead, they invade. They destroy the tissue around them. They send out those tendrils.
The crab-like pattern of growth.
That's the one. And even if a slow-growing cancer seems to have a capsule, if you look closely under the microscope, you'll see tiny little tongues of tumor infiltrating that margin.
Which is why the surgery is so different. You can't just scoop it out.
Exactly. For a malignant tumor, a surgeon has to take a wide margin of what looks like perfectly healthy tissue around it, just to be sure they've gotten all those microscopic invaders. Next to metastasis, this local invasiveness is the most reliable feature of malignancy.
And that brings us to the third and maybe the most definitive pillar of distinction, metastasis.
This is the one. If a tumor has metastasized, if it has spread to a part of the body that's not physically connected to it, it is, by definition, malignant.
Benign tumors never do this.
Never. And metastasis is what really changes the prognosis. The stakes get so much higher. Our sources say that about 30% of patients with solid tumors already have metastases when they're first diagnosed.
Wow, that's a sobering number. And we should be clear, invasiveness and metastasis aren't exactly the same thing, are they? Some tumors are one, but not the other.
A very important point. Think of gliomas in the brain. They're horribly invasive, they destroy brain tissue, but they almost never metastasize outside the central nervous system. Same with basal cell skin cancers.
Locally aggressive, but they stay home.
Right. And then you have the liquid tumors, leukemias, and lymphomas. They're considered malignant from the get-go because their cells are already circulating in the blood and lymph. They've already spread, in a way.
So if a solid tumor is going to spread, how does it do it? What are the highways it uses?
There are three main routes. The first is seeding of body cavities. This happens when a tumor breaks through a wall into an open space, like the abdominal cavity.
The classic example being ovarian cancer.
Right. Exactly. It can coat the surfaces of all the organs in the abdomen. Sometimes mucus-secreting tumors can fill the whole space with this gelatinous material. It's called pseudomyxoma peritoni.
Okay, what's the second and more common pathway?
That would be lymphatic spread. This is the favorite route for carcinomas, which are cancers of epithelial cells. The tumor cells basically follow the body's natural drainage system.
So for breast cancer, it would go to the lymph nodes in the armpit first.
To the axillary nodes, correct. And that's why the sentinel node biopsy is such a brilliant technique. We find the very first lymph node on that drainage path.
The sentinel on guard.
Precisely. And if that node is clean, there's a very high chance the rest are too. It saves patients from much more expensive surgery.
But just because a node is swollen, it doesn't automatically mean cancer, right?
No, absolutely not. The immune system could just be reacting to the tumor, causing benign swelling or hyperplasia. You always need a biopsy to confirm.
Okay, and the final highway.
That's hematogenous spread, or spread through the blood. This is the typical route for sarcomas cancers from connective tissue, but aggressive carcinomas use it too.
And they tend to invade veins more than arteries.
Yes, because veins have much thinner walls. The cells break in, get swept into the bloodstream, and then they tend to get stuck in the first capillary bed they hit.
Which, because of how our circulation works, usually means the liver and the lungs.
the body's two great filters. That's where you see the most common blood-borne metastases. But here again, cancer has surprises.
How so?
Some tumors, like renal cell carcinoma, have this bizarre habit of growing inside big veins. They'll form a long, continuous snake of tumor up the vena cava, sometimes reaching all the way to the heart. It shows you it's not just simple plumbing. There's a complex biology at play.
Okay, so those pillars give us the classical definition, but modern pathology helps us understand the why. This is where the molecular reality comes in.
Right, and a concept that perfectly bridges that gap is carcinoma in situ, or CIS.
Explain that. What is it?
CIS is a lesion where the cells look completely malignant. They have all the anaplastic features we talked about, the ugly nuclei, the pleomorphism, everything. But there's one crucial difference.
It hasn't broken out
It
yet.
hasn't broken out. It's like a tiger in a cage. All the features of a killer, but it's still contained. It has not yet penetrated the basement membrane, that floor of the tissue.
So it hasn't become truly invasive.
Not yet. But it's a precursor with a very high chance of doing so. It's sitting right on the edge.
This helps explain the risk profiles then. Why is something like a lipoma almost never going to become malignant, while something like a colonic villus adenoma has a 50% chance of progressing if you don't remove it?
The molecular story tells us why. It comes down to genomic instability. That benign lipoma is stable. It might have mutation, but its DNA repair kit is mostly working.
But the villus adenoma...
The villus adenoma is unstable. It's already accumulated multiple mutations, and critically, it's probably lost the ability to police its own genome. It's prone to making more and more mistakes.
So it's not just the mutations it has, but its ability to acquire new ones really fast.
Exactly. It's genetically primed to take that final step to acquire the mutations it needs to invade and metastasize. The molecular biology explains the risk that pathologists have been seeing under the microscope for a century.
So this has been an incredible deep dive. We've seen cancer isn't one thing. It's a diagnosis made by looking at these 4 key characteristics. Benign tumors are well-behaved, they're differentiated, encapsulated, and they stay put.
While malignant tumors show the cellular chaos of anaplasia, they invade like a crab and they have that terrible ability to metastasize through the lymph, blood, or by seeding.
We rely on those features to define and treat the disease.
We do. And yet, for all we know, that final step, metastasis, is still deeply mysterious.
Which I think raises a really important final question. We see tiny, well-differentiated tumors that spread everywhere, and then huge, ugly, invasive tumors that stay localized for years. It doesn't always follow the simple rules of drainage. So this is the question to leave you with. What is the specific complex interaction between a tumor cell's own aggressive genetic program and the unique environment of the host's body that truly decides its ultimate metastatic destiny?
Understanding that dialogue, that's the next frontier. That's where the next real breakthrough is going to come from.